Joel,
Rob, how are you?
good, good. You're looking pretty sharp there.
It's not easy for me.
Oh, you got the flags and everything. Is that the Florida flag or the next to the U.S.?
Hello, I'm Dr. Joel Silverfield, President of the Hcma. We are pleased to hold this virtual membership event in lieu of the Hcma's normal membership dinner. We're all saddened that we can't get together with our friends and the medical students and the people from the medical school and have our normal meeting, but it's good to have one tonight because we're going to have a wonderful speaker and it's going to try to be as close as we can to the real thing. It is our hope to resume our membership meetings in 2022. But like a patient today, I was asking a patient of mine when she wanted to have a real visit, and she says, I guess when this COVID thing is over. So I asked her, when is that going to be? For the best view during this evening, please make sure your screen is on gallery view. At the bottom of your screen, there'll be a chat option, which you can use later after Dr. Caleb and I speak for options. I would like to introduce those who have joined me on the screen tonight, Dr. Robert Caleb, who I'll introduce in a moment, and Dr. Maureen Maciel, Medical Director of Shriners Children's Florida Hospital. So just a brief summary. As you know, we have had some difficult times, as has everybody, but our HCMA has tried to stay relevant. We've done a number of things over the past year that some of you may or may not be aware of. We have had a wonderfully successful physicians wellness program. We actually started that before the pandemic because we were noting that a good number of our physicians were having burnout and other issues with mental health, candidly, and now with the pandemic has gotten much worse. So we set up a program where all of our members can have 6 free visits, totally confidential. There are no notes, there are no diagnoses, with psychologists that we have vetted. So it's a great program, particularly for our younger doctors. During this past year, we've put on 7 COVID seminars. We have been joined by Dr. Charlie Lockwood, the Dean of our medical school, Dr. Sennett, the head of internal medicine and head of infectious disease and epidemiology, Dr. Holt, who runs our Florida Department of Health, and then Margarita Cancio, who is a professor of infectious disease. These seminars have been very well received, and I think they've done a lot to keep our county up to date. The other thing that was done early on, as you know, many of us who are in private practice were unable to get medical equipment. So we were able to find a source that would get us masks and gloves and all the things we needed to run our offices. So the Medical Society did that early. The other thing that we did was there was a shortage of vaccinations for medical personnel. So we were able to find vaccinations so that our doctors and nurses could get safe. From a financial standpoint, we made the decision as a board to sell our building of many, many years. And that sale went very, very well. And candidly, it has set our medical society up for many future generations of doctors. We are very strong financially. And that's in contrast, unfortunately, to our surrounding counties of Pinellas and Polk and Hernando. Those societies actually have become moribund and are really not active. We are actively now ourselves reaching out to the members of those counties so they can have a voice, and we're going to hope that they will join with us in our county. We do a great deal of legislative work. Now, it used to be said that a great offensive lineman in football was one whose name was never called during the game. And our CIA and other groups are claiming that they don't get the credit for thwarting terrorist attacks that you never hear of. And that's sort of what the last year's legislative session has been. It's really been the work trying to get some of these attacks on practice of medicine thwarted and avoided, because our legislature, as you know, can be quite cutting edge in some of the things they want to do here in Florida. I want to thank Dr. Michael Cromer and Dr. Eva Crook, who have been excellent advocates for our society. As you all know, we have an HCMA foundation. We take giving to others and helping other folks who are not as solvent as we are. And we've been very pleased to make donations of a substantial nature to several important local charities. We all represented you and went to the FMA meeting in Orlando. That went very well. Very impressed by the doctors who are out there working, trying to keep our profession as excellent as it has been through the years. And then a final thing, this is Women in Medicine Month. On September 23rd, Judy Lisi, who is CEO of the Performing Arts Center, is going to be addressing women in medicine. So that should be a very good one. I'm pleased to recognize our two sponsors this evening, Shriners Children's Florida Hospital. And with us tonight, we have Dr. Maciel, who is representing them. Ever since I've been in Tampa these many years, Shriners has always been such a great organization, has done so much for the children of our area. And I just wanted to thank you again for being one of our sponsors as well. Dr. Maciel has some remarks she would like to make.
Sure. Well, thank you for having us. We're happy to participate and help support the HCMA for these wonderful meetings, which again, hopefully will be in person at some point in the future. But thank you for putting them on in a virtual format so we can all enjoy them. Shriners Healthcare for Children sits on the USF campus, and we offer outpatient pediatric orthopedics, as well as rehabilitation services, orthotics and prosthetics, seating services, and pediatric endocrinology. We see children for all pediatric orthopedic conditions, regardless of ability to pay. Our system's long history of taking care of children with unique orthopedic care, which began with polio, lives out in the very specialized care we provide in the fields of metabolic bone diseases, limb deformity and deficiency, scoliosis, and neuromuscular diseases. Our dedication to quality and safety is demonstrated in the technology that we offer. We obtain our spine and lower extremity films using an EOS machine, which delivers 1/3 the dose of a conventional X-ray. This is really important for our patients because many of these patients receive multiple X-rays throughout their childhood, and that has an additive effect. So we feel that this is really important for patients getting these X-rays, so we're happy to be able to provide that. We also recently opened our Motion Analysis Center, where we perform comprehensive gait analyses on patients with gait disorders. In these studies, we can accurately diagnose the origin of the gait disorder, and this guides our treatment both surgically and non-surgically. So we can evaluate patients in many dimensions, analyze all parts of their gait, make some decisions about treatment, and then actually follow that patient up a year later and analyze the outcomes of those treatments. Being in Shriners means we're part of a multi-system, multi-site system, so we can collaborate with our fellow Shriners sites to really gain some wonderful information using our motion analysis centers. We also have multidisciplinary osteogenesis imperfecta and muscular dystrophy association clinics. And in these clinics, we offer clinical research to include pharmaceutical clinical trials, which have been really promising in some of our Duchenne muscular dystrophy patients. And some of you probably know that we did transition from being a hospital to being an outpatient healthcare site. And we partnered with Tampa General in 2018 and moved all of our operative services to Tampa General. That partnership has been very successful and has truly expanded the operative and perioperative services that we are able to provide. In our scoliosis surgical service, we work with the other disciplines to include plastics and neurosurgery in order to provide even higher level care to our high-risk spine patients. And in this approach, they have lower blood loss and much better healing potential. We've really enjoyed working with our pediatric partners there, and we feel that we've been able to elevate the perioperative experience of our patients. And I think that this is a partnership that's just going to continue to grow and expand and benefit both organizations. So I'm glad we can both be your sponsors tonight, and thank you very much for this this time to speak about our services.
Thank you so much for your time and your sponsorship as well. I'd also like to recognize and thank Tampa General Hospital. Tampa General Hospital has been a big part of supporting HCMA since its very foundation. They've been a great friend to our society, and they're one of our big sponsors tonight. I'd like to ask for your attention as we present a brief video about Tampa General Hospital.
At Tampa General Hospital, we heal, we teach, and we innovate, caring for everyone, every day, to deliver world-class care you can't get anywhere else in Florida. It's more than a statement, it's a commitment, with a body of proof you can see and feel. For over a decade, we've been named one of America's best hospitals by U.S. News and World Report. We're the area's only American College of Surgeons verified Level 1 trauma center and the first verified Level 1 pediatric trauma center in the state. We're the area's first and largest teaching hospital with the region's largest neuroscience intensive care unit. We're one of the nation's top 10 transplant centers and one of only 2 verified adult and pediatric burn centers in the state. We have 5 medical helicopters transporting patients to Tampa General for care. Our state-of-the-art neonatal intensive care unit is one of only a handful in Florida to deliver the highest level of care to premature and critically ill newborns. And our orthopedic program is the best in the state and one of the top 20 in the nation. We were the first in Florida and one of the few in the country to perform single-port robotic surgery. And our surgical oncology program uses robotics and a multidisciplinary approach to manage some of the state's most complex cases. Our partnership with the USF Health Morsani College of Medicine trains more than 700 residents and fellows participating in over 60 training programs and helps fuel hundreds of research studies across multiple disciplines. And our strong collaboration with private practice physicians helps pioneer programs and deliver superior patient care. We're a nationally designated comprehensive stroke center with a dedicated team on site 24 hours a day, 7 days a week. We are Magnet recognized for nursing excellence, and for the 7th consecutive year, Becker's named us one of America's 100 great hospitals. Why do these certifications, verifications, and awards matter? Because we adhere to rigorous standards, measuring ourselves against the best in the business, so the care we deliver continues to raise the bar, as does the economic impact we have on our community. For nearly 100 years, Tampa General has been caring for Tampa Bay and beyond. And as we move toward the next century of care, we're building on this legacy with a strong strategic vision. Our team of more than 1,200 physicians and over 8,000 healthcare professionals is focused around one single goal: to be the safest and most innovative academic health system in America. How? We differentiate ourselves on value, not volume, like pioneering treatment and community response protocols for COVID-19 and other infectious diseases through our Global Emerging Diseases Institute and the TGH Prevention Response Outreach Program. Our Zero Harm initiative ensures we never compromise quality, safety, outcomes, or service. Our CareComm Center, an over 7,000 square foot technology hub built in partnership with GE Healthcare, marries artificial intelligence and predictive analytics with human ingenuity to empower our team and provide a superior patient journey. And our People Development Institute allows us to attract, retain, and train our healthcare professionals to think differently about how they deliver care and become true patient advocates. That's why we're expanding our footprint across the state to diversify our services and deliver more patient-centric areas of care. In fact, we've more than doubled our reach to offer more services to more patients, where and when they need it most, in Tampa Bay and beyond. Leading by example, innovating at every turn. That's world-class care. Tampa General Hospital. Other hospitals practice medicine. We define it.
Thanks again to Tampa General for being one of our sponsors. We're now going to get to some of the heart of our program. I'm going to take a couple of minutes to introduce our number one guest, Dr. Robert Califf. Dr. Califf and I will participate in a fireside chat. If you have questions that you would like to ask Dr. Califf at the end, there is a chat option at the bottom, and we will take those questions after it's done. For most of us physicians who are down in the trenches seeing patients, Dr. Google is an accomplice in the many ways. It can be either the patient commonly bringing in things they found on Google and asking us questions, or for me, a lot of times when a patient comes in with a rare disorder, I'm secretly looking it up on Google. So tonight, for our first meeting for this year, we're actually bringing in Dr. Google, Dr. Robert Califf. So Dr. Califf is a Duke summa cum laude undergraduate. He went to Duke Medical School. He did his cardiology fellowship at Duke. He's the founder of the Duke Clinical Research Institute, which is the largest of its kind in the world with over 1,000 employees. He's in the top 10 most cited medical authors with over 1,200 articles. He was the FDA commissioner under President Barack Obama. But most importantly, and the reason I think he's even more interesting is he's the chief strategist for Google and Verily Health. You wonder, how do I know all of that? Well, it's simple. First of all, I Googled him. But secondly, I went to high school with Dr. Califf. He was one of those people in high school, brilliant student, great athlete, and then married the most popular girl. But the final insult that I found at our recent high school reunion is he's kept all of his hair. So we're going to ask Dr. Califf some difficult questions tonight. Some of them I think you'll find interesting. So Dr. Califf, of all the accomplishments in your life, have there been any that were as big as winning the state championship in basketball? You were the captain of the team. Here is a picture of Dr. Califf. It's sort of dark there, but I think we measured it, 8 inches of vertical. He's going in for a layup here. Was that the crowning achievement of your life, do you think?
I think the crowning achievement was marrying Lydia, as you said,
That's
going on 47 years now. So that's the biggest thing. But I'd say very little to compare with winning a state championship in basketball. You feel like that day you are the most important, special person in the world. Then you wake up the next morning, you're just an average Joe again. But that's okay. And you know, it was kind of funny when I met President Obama for the first time. In the briefing, they said he's going to know that you were captain of your state championship team, but he was too at Hawaii in his high school, and he loves UNC, he hates Duke. So get ready for it. And literally, in the interview for commissioner, which was 30 minutes one-on-one in the Oval Office, the first 15 minutes was nothing but how much he hated Duke basketball and how great he thought the Tar Heels were.
Oh my God. You didn't play one-on-one by any chance, did you?
Well, it got a little testy, and as they predicted it would, and I challenged him. I knew he had a goal out in the lawn there, the Oval Office, but he claimed his knee was hurting him, and so we decided not to go at it.
Did you vote today? I'm wondering if California Governor Newsom is going to be recalled. What do you think?
Well, I think it's unlikely he'll be recalled. It's a very Democrat state, but I didn't vote because my residence is in North Carolina. In fact, although I've got my picture, we actually live right underneath the Golden Gate Bridge in the Presidio when we were in California, but we're actually back in North Carolina today in the Bull City of Durham.
So that's not the view out your window right now.
It's
So when you were serving as FDA commissioner, what was your biggest and most difficult decision?
well, I'd say the biggest decision was how to steer 21st century cures through Congress and all the other elements. Some of you may know that was a major bill that went through that added a lot of funding to the NIH, specified a lot of things for FDA, put in a whole bunch of helpers for dealing with electronic health records and patient access to medical records and all sorts of things. And I knew when I took the job this was going to happen, but I'll tell you, the bill, a major bill going through Congress is really something to deal with. I'd also say there's no reason why the average person would ever have to think about this, but the FDA is about a $5.5 billion budget a year. There's 17,000 employees, and over half the money comes from user fees. And every 5 years, there's a major negotiation between the FDA and the related industries over how much they're going to pay and what the quid pro quo is, what they're going to get for that payment. And that's all adjudicated by patient advocacy groups. And then ultimately it's put into a bill that Congress has to pass. And that happened on my watch also, which was really a fascinating experience to see what the relevant industries thought about their own regulation.
You know, I think I read something recently that said that you're right, that so much of the discoveries that were made in the government laboratories that were translated into in the private sector. But now I read recently that there's more and more now coming out of the private sector than there was from the government sector. Is that what you're hearing?
Well, what I'd say, Joel, is that it's an artificial distinction. I mean, there's no question that the commitment of the federal government to fund basic research of all types, the fundamental discovery research that's not intended per se to develop a new product, that is really at the basis of just about everything that comes out of the biomedical enterprise, whether it's engineering of devices or whatever. But the medical products industry, the drug, biologics, and device companies do an enormous amount of development research and all the clinical trials you know about on top of that. So I think it's not one or the other. It's really best seen as a hand in glove where each has an important role to play. And in fact, that was a lot of what was at stake in the 21st Century Cures Bill, was making sure that the NIH got the money it needed to supply the fundamental, like the Human Genome Project would be an example. That turned out to have a private component and a major public component, but you needed both. And, I could give a lot of other recent examples where that's been critical. And don't forget that we all get trained as PhDs or MDs in academic medical centers, which are heavily funded by the NIH. So we need both would be my view of this.
What is your opinion on the FDA's decision to approve the Alzheimer's drug Hcma? There's a lot of controversy out there.
Yeah, that's a really hard one because it was an unusual route that the FDA took after looking at, as you know, the clinical trials didn't meet expectations. But there's a law passed by Congress that gives the FDA the authority, if it's for a disease that has no highly effective treatments and has an almost uniform bad outcome, to use what's called an accelerated approval. And that authority gives the FDA the ability to say, we'll put this drug on the market based on an unproven biomarker, not something that's proven to predict outcome, but for which it's reasonably likely is actually the term that's in the law. And that happened because patients demanded it. They said, patient groups got together and said, we can't, if we got a disease from which we're going to have a bad outcome and there's no effective treatment, we want to have access to that treatment earlier, and we're willing to take the risk. But no one had Alzheimer's disease in mind when those laws were passed. So this was a new thing. The criteria were really, the improvement in the amyloid plaques that was seen, and that is highly questionable, I would say. One thing I want to point out, the FDA commissioner is in the line of authority for approval of drugs, but for a whole bunch of reasons, that decision is made 99.9% of the time by the relevant head of the unit at the FDA, either the Center for Drugs or the Center for Biologics or the Center for Devices. And just to give you the fundamentals of that, the reason is that the commissioner is a political appointee. The courts defer to the FDA almost routinely because it's a science agency. And the idea is that a civil servant should really be making those decisions. So there've only been 2 or 3 times in the history of the FDA where the commissioner has actually overruled a group. So you asked me what I would do. I don't have access to all the data, so I can sort of skirt the question, but I'd say this one, I would have to see something more than I've seen so far.
I know a couple of highly respected researchers at the FDA resigned in protest when that happened. There are also a couple of other recent FDA high-level folks resigning. I know Dr. Gruber had been there 32 years over this vaccine booster decision by the Biden administration. What do you think about that?
Well, I'll be a little careful attributing one motive to people stepping down from the jobs at the FDA. I mean, 32 years is pretty long and solid career, and a lot of people at FDA are very tired right now, just like the medical community. It's been a sprint now for 18 months. But you may have seen that Dr. Gruber and colleagues published an article in Lancet yesterday that laid out their concerns about the booster decision making. And it's another one that, there are 2 sides to the coin. I'd say whenever you're in government at a high level, you're constantly every day asking the question, do I go with the plan, or do I object to the plan enough that I really can't be part of this effort? Because, there's not 100% agreement about anything, especially scientific issues.
No,
and so there are always things that you disagree with, but if you're in the FDA, you're part of the executive branch of government. There actually is a reporting chain that goes, from the employees at FDA to the commissioner, to the HHS secretary, to the president. So the commissioner is just really 2 levels below the president. So what I would say about the boosters, though, I'm thinking about this a lot right now. You and me, I don't know if you've hit the magic 70 yet, but I'm going to at the end of this month. And so I officially qualify as elderly in the vaccine world, and I'm watching it pretty closely. There's going to be a hearing at the FDA with the advisory committee on Friday. I think one thing that was misunderstood, I think there was some bad choice of words in what was said, that the boosters are going to be made available pending FDA decision making. Well, there actually is an FDA decision to be made, and the independent advisory committee will have a big say in that. And even if the FDA said, let's make the booster available, then the CDC actually has to also agree in the case of deployment of vaccines. Now, as you also know, in the right to practice medicine, any doc can prescribe the Pfizer or Moderna vaccine now because they're on the market. And it might be an off-label prescription, but you could do it if you wanted to.
Right.
My take on the data is that boosters are going to be helpful, and I think the most solid evidence is from Israel, where they've now deployed the booster, and it has a pretty dramatic impact on infection rates. In a case where with Moderna, with Pfizer, which was uniform in Israel, there was a definite waning of immunity, and they've now got the data. Just a new publication today showing it has a pretty big effect. So I think we're going to be getting our boosters, people like you and me, here pretty shortly.
Well, don't tell anyone, but I've already gotten mine. Do you think dietary supplements should be regulated by the FDA?
Absolutely. I think there are only two kinds of medicines: those where the benefits outweigh the risks, and those where the benefits don't outweigh the risk. And I don't think ingesting dietary supplements is any different than ingesting a pharmaceutical. The history of this is kind of interesting, at least to people like me. This goes back to the time when David Kessler wanted to regulate tobacco. And you may remember, you and I were youngsters at the time, but they raided the Philip Morris corporate offices under court order and discovered all these documents about how the tobacco companies were spiking through genetic breeding, were growing plants that were high in nicotine. And they had documents showing the goal was to addict as many teenagers as possible, because that would produce, quote, a customer for life, unquote. But this was very controversial in Congress at the time. And in order to swing the deal, Kessler cut a deal with Orrin Hatch, who a lot of the nutraceutical industry and dietary supplements were in Utah at the time. And the deal was, Hatch said, you can regulate tobacco. In return, we'll put through a regulation on dietary supplements that exempts it from pre-market evaluation. And that's what happened.
Wow.
Now, unfortunately for Dr. Kessler, this is a part of the story people forget. Congress said, yeah, you can regulate tobacco, but then the tobacco industry took him to court and won in a 5-4 Supreme Court decision. So it was only in the first year of the Obama presidency that Congress passed a law that could override the court decision and enable the FDA to regulate tobacco.
That's amazing. I did not know that story. One of the most common uses for Google searches is medical searches. Is there a large team of medically knowledgeable staff at Google vetting all this information?
Well, there is a large team of medical staff. And just to give you a little orientation, Google search is a big thing, and it had, a very high proportion of global searches use Google search. It's available in every language known to man. But people in my generation and yours often forget about videos. There are entire generations of people now who don't read much. They just look at videos. So YouTube, believe it or not, is now the #2 search engine in the world. So both under the Google tent. And in India, for example, with 1.4 billion people, YouTube is far and away #1, because in general, India is more advanced in cell phone technology than we are in the US, and people look at videos on their cell phones to get information. So across Google, we have a function in Google Health, which essentially, everybody on this in this meeting has been through an academic medical center. So if you thought about search and YouTube and Maps and Android, they're like departments of medicine, surgery, anesthesia, and pathology. And then the docs who are in Google are like a center or an institute, serving those core departments with expertise, because to those groups, they're run by engineers, not by medics, obviously, and health is only one part of what they do. But you asked the question, do they vet the information? And here's where it gets complicated and sticky, because we live in a society that believes in the right to free speech. It is the First Amendment. And globally, there's great support for free speech. And so when you say vetting it for veracity, yes. In fact, there's a random selection of information. And, this is really interesting in the video category, as you might imagine. And there are teams of doctors actually on contract all over the world who vet this information. but you can only take down information which is directly harmful. So examples would be child pornography or terrorist inciting violence. But untruthful statements that are not directly harmful is a very worrisome category. And I'm sorry to say a lot of that's being done by doctors. So I sort of, the issue we got to grapple with is how do we steer people to truthful information and get rid of the directly harmful stuff, but still retain the right to free speech that people have. And then let me just tell you one other thing, because I'm pretty excited about this. I'm doing a lot of work with YouTube now. I'm learning a lot. It doesn't come naturally to me to search out videos as a normal way of getting information. But what we decided to do now, we worked with the Institute of Medicine and got the IOM, now the National Academy of Medicine. I'm a member, so that was kind of fun for me to identify the qualities of an organization that would be considered high quality. And as you might imagine, these are mostly health sciences centers and schools, professional societies, journals. And we're labeling those now as being reliable and creating what's called a corpus, or a body of literature, in this case, a collection of videos, that if you're out there in the public, it's fair to assume that these are organizations that would not do well if they were lying or saying things that just weren't true. Their reputations are at stake. And our goal there is to have competition among those entities to get to the top of the heap, because one of the interesting things I've learned about, if you take the really truthful, reliable information and put it in a batch, it's mostly really boring to the average person. It has a lot of jargon and medical terms and stuff that the average person can't relate to. You take the bad stuff, it's pretty exciting stuff. It's really presented in a way that's attractive to the public. So if our goal is to help the public understand what to do about their health and their medical decisions, we got to get you guys in bow ties into the mainstream of being attractive to the public out there. Because, if you think their 15 minutes in your clinic is the only way they're deciding what they're going to do, I know you don't think that, but it just doesn't work that way. They're at home almost immediately looking to try to figure out what the hell you were talking about. So I really hope that medical groups and docs will get very involved, because the cat's out of the bag. It's happening. People are looking, and we would really like to see a tremendous preference for reliable, useful medical information.
Well, I understand that. It's interesting. When my patients who come into the office with vaccine hesitancy, and I spend a lot of time trying to talk folks into getting the vaccine, they really are on fire when they say, well, I read this thing that this doctor said. So you're right, when a doctor says it, it does have great credence. Unfortunately, when I say it, it doesn't seem to have a lot of credence. So maybe you're right. I don't know how to say it.
Well, another way I think about this, just to say it, is when people say, why don't you just put reliable, accurate information out there, try to get two doctors to agree on something.
That's right.
There's a lot of, there are only a few things we really agree on, but people need the best information they can get.
No, that's a good point. I know it is important to you personally and to Google to have equality and inclusiveness in the vaccine process. Could you tell us about the vaccine equity planner and how that gets translated into getting more vaccine into minority arms?
Yeah. So first of all, let's go back to the very beginning when, one of the interesting things about my job, since Google is or Alphabet, the parent company, and I work half on the Google side and half in a company called Verily, which is part of the Alphabet family that does regulated biomedical stuff. We got over 130,000 employees and several 100,000 contractors all over the world. And since we're dealing with information, we see information about things happening, I would just say on average, well before, it's in the common vernacular or even in the news very often. we could see the pandemic shaping up pretty early. And we put into place a program in alliance with government entities to move the reliable information to the very top of the stack and make it pretty hard for people to get unreliable information. But we can't make it impossible for the reasons that I gave. And of course, the anti-vax industry immediately went to work to try to circumvent any maneuver. It's a cat and mouse game that we have to play. But, you know, we were all concerned about the history with the known issues with Tuskegee and all of the issues that minority populations have, that there was going to be this disparity in vaccination. And in fact, it started out that way. So, you know, one of the things I did early on that was a lot of fun was getting Dr. Fauci up with a famous rap star to go on YouTube, and that got like millions of hits. A lot of people watched it, and I think it had a big impact. But, you know, it's been interesting to me, once we get into that narrative, it's hard to change it. So if you look at the data today, it's definitely true that deprived neighborhoods, people who live in deprived neighborhoods, socially deprived, something called the social deprivation index, are much less likely to be vaccinated than people from, I'll just say, socially well-to-do neighborhoods. But if you look at it by minority status, we've actually largely succeeded with vaccinating the minority population, and we've won the battle over trust in the vast majority. The biggest holdout now are the people we grew up with, Joel, the rural white conservative evangelical population. And then there's one other fascinating holdout population. In a recent poll that Kaiser Family Foundation did, the most resistant core of people are people with PhDs.
Huh.
And they didn't ask what kind of PhD, and most of us are, there has to be a follow-up survey, but most of us are thinking these are probably people with liberal arts PhDs who have grown up in an environment where you're suspicious about the sort of science conglomerate and what it says. But I do want to point out that this worked with minorities. I mean, the confidence in vaccines is high, and the vaccination rates are actually better now than compared to rural evangelical white people. We did also go to work on them, I have to say. We had some great videos with Richard Petty and various people like that. But, you know, a sad part of our society now is we had several really prominent country music singers and NASCAR drivers who stopped because they were getting so many death threats. So really serious business.
You wrote an article called, Can We Stop This Tsunami of Common Chronic Diseases in the Post-Pandemic Era? It's been a highly cited article. What were you trying to get at with that article?
Well, let's go back 10 years. About a decade ago, the US started on a course of a decline in life expectancy. And the UK had a minor version of that, but these are distinctly different statistics than we're seeing in any of the other high-income countries. And right before the pandemic, we were looking at data showing that the average US life expectancy was 3 years shorter than the average for the other high-income countries. And we were far and away in last place and losing ground every year, year by year. And the reason, you know, it used to be we worried about infant mortality, and we still should. But the big change is that Americans are dying of common chronic diseases that we know well: coronary disease, heart failure, cancer, kidney failure. And then COVID hit. We took a big hit, more than almost any other country, as you well know. Florida certainly has paid the price in a major way. But what we haven't talked about much is that cancer and heart disease deaths still exceeded COVID-19 deaths throughout the pandemic. And as you know, many people have not attended to their health issues because they were afraid to come into the doctor, or they couldn't afford it, or they were distracted. So we're going to have an avalanche. I don't think doctors have to worry about being employed anytime in the near future, because there is a huge wave of common chronic disease when we get COVID under control that we're going to be dealing with. And that was really the goal of the article.
Very good. Why do advances in medical science and technology not save money like they do in so many other sectors? I think about robotic surgery, new drugs, EMRs. In fact, they did an EMR study a couple of years ago, and they found that really of 26 quality parameters, EMRs only improved one, which was diabetic diet. So the question is, we got these new drugs coming out, we have these new technologies, but they really don't seem to save money, whereas other technologies seem to.
Well, I think that's such a complicated question. I'll try to be brief, Joel, at least in my views of it. And, you mentioned your medical society not having PPE and having to go get it yourself. I'm on a National Academy of Medicine committee on the supply chain that was, Congress asked us to be one of several groups taking a look at what happened with the supply chain and what we can do to prevent these kind of problems when we have our next disaster. And a professor of industrial engineering who's on the committee, who was not involved in healthcare at all until we started meeting, in the last meeting said, I finally get it. The business of healthcare is thriving. The healthcare system is an abject failure. And what he's referring to is that more money is being made now than ever before. It's a $3 trillion part of the economy, but our life expectancy is going backwards. That doesn't make sense, does it? And I saw the beautiful movie of Tampa General. There's a lot of fantastic technology, but it's almost as if in America, we're inventing the technology, which we are. We're the most creative society in history, and we still are. But other societies figure out how to use it for the health of their populations. So, and I think the fundamental problem is what I call sub-optimization. There's a great New England Journal article that when you first read it, you wouldn't think it had to do with a business principle, but came out about a year and a half ago, and it was about a man who thought he had pancreatic cancer, had a Whipple procedure, and went through all the follow-up, and a year out, someone happened to mention that he actually didn't have pancreatic cancer in the first place, but nobody had thought to tell him that. And he actually was a happy man because he had survived all this. And the point of it was that everything in the system worked. That is, he had a major operation, he had all the tests and follow-up, he had all the visits and everything, but the purpose of it was completely lost. So the parts didn't add up to a whole that was positive. And I think that's what we have in the American healthcare system. We're not connected in a way which yields a product that is better health, that's a product we should be generating.
No, I don't just, in fact, you reminded me, I read an article recently, it was talking about we are undeveloping as a developed country. We are undeveloping. Our lifespan is down. We're not spending on infrastructure. Our educational system is a shambles. We're not doing anything for future generations. So you've made me think about that article, which says we are actually an undeveloping country in many ways. Let's see here. So everyone hears about IBM's Watson and how it operates about like a second-year medical student. Tell me about DeepMind, which is Alphabet's intelligence arm, which they put under the Google Health Division. I thought that was interesting. They were taking this big AI project and putting it under Google Health. Well,
First of all, you gotta, obviously I'm biased here. I have a little bit of a conflict. I happen to work for the company, and I think it's an unusual company in the history of the world in terms of its span, multiple products that reach over 1 billion people a month. And a byproduct of the significant profits that are made is, you may remember a thing called Bell Labs. It was famous because in those days, Bell was making a lot of money, and a significant part of it was put into a part of the company that was just there to innovate. And Google does that. Every Google employee can spend 20% effort on whatever they want to do. And there are an enormous number of people who are hired just to develop new methods of artificial intelligence and computing. So if you go to the academic meetings on artificial intelligence and machine learning, Google outpaces the leading academic center 10-1 in terms of publication. So DeepMind is only one part of it, but just think of Google as a massive effort where the next phase that we're in the middle of right now is to make machine learning and AI just a part of everyday life, not something that's special. So DeepMind is partly within Google Health, but it spans other major areas of enterprise too. So simple way to think about this is think about maps, right? You remember 15 years ago, you wanted to go from Tampa to Miami, you'd get out your paper map and put it in your glove compartment. And if you got lost, you'd pull off to the side of the road and unfold the map. And God forbid, you might have to roll down the window and ask for directions. If you're a man, that's a very hard thing to do. Now, what do? You get in your car and you either talk to your car or you talk to your phone, and it talks back to you and tells you where to go. Well, that's happening because we've mapped every road in the world and we keep it up to date. And while you're driving, we're assimilating data from all over the world about potholes and crashes and weather conditions, and artificial intelligence is building that into algorithms paired up with what the system has learned about what you like to do, the routes you like to take, and it gives you suggestions. So when you ask what's the ultimate goal of this, why is it that we can have that when we want to go somewhere in a car, but the poor soul trying to find the rheumatology clinic often is lost trying to get there and is ill prepared, and the poor rheumatologist is fumbling through electronic health records with very little functional decision support. So we're trying to build something that'll be helpful in that. Unfortunately for us, the human being is about a gazillion times more complicated than roads, and it's going to take a while to do it.
You're making me think about Haven, which was the Amazon, Berkshire Hathaway, and JP Morgan. They got together a few years ago, and they were just gonna, like you say, healthcare is 1/6 of the economy, $3 trillion. So these brilliant, very successful companies were all going to get into the healthcare business. And then after 3 or 4 years, Haven went away. And what is your take on that?
Oh, I know a good bit about it. Even Mr. Trump figured out that healthcare was complicated, right? I think there was a famous quote about that. And I think they made an earnest effort. They really couldn't overcome the complexity of the three-way. I mean, if you think about the egos involved between Amazon, Berkshire Hathaway, and the third entity, it just wasn't going to work. But one of the characteristics of these kinds of enterprises is it's okay to fail, because what happens with failure is that a lot's been learned and then new things happen. So keep your eyes open for Amazon right now. You may see a guy named Vin Gupta on CNN periodically talking about COVID. He's kind of an amazing guy. He's an intensivist. He's in the Army Reserves, and he's also the head of healthcare for Amazon right now. And they're going to give a run on the logistics of medical supplies and pharmacy and primary care. So I think a lot was learned through that, and it's going to play out in ways that maybe you wouldn't have thought about, but you'll see the connections as time goes on.
My son works for Amazon. I don't doubt they can do just like Google about anything they put their mind to. Let's see here. Why do people, and I know you were involved heavily in clinical research with pharmaceutical companies for years, why do the people in our country pay 4 times on the average as much for medication as people in other countries?
Okay. This is it gets political. There's no way around it, because the fundamental answer is political. I would say but we do have to start with a basis. And I used to give lectures on this in business schools. It is a fact that most things we pay more for them in America than other countries. And that's considered fair and just in the business world because we're richer than any other country. But the question is what we're paying for drugs compared to other countries within the proportions that you would expect for other things that we purchase in the US? And the answer to that is no. So if we cede a certain amount of more payment, and then we might even cede a certain amount more beyond that, because frankly, it's in America's interest to be the home of biopharmaceutical R&D and the companies that are in charge of that for a whole variety of reasons. There's an economic benefit that we get in payback. And we also have, at least in theory, some control of the supply chain, which may turn out to be critical at times. But we still pay even more compared to that. And the fundamental problem is that there's not a reasonable negotiation with the pharmaceutical industry in the US. And in Europe, in Japan and Singapore, for example, there's not just approval by the FDA-like agency and the payment by the payer. There's an intermediate step called the health technology assessment. And that's a governmental function to say, what's this treatment really worth? That leads to a bargaining negotiation. And this is my explanation of it. And because the companies cave in other countries, and there is no ceiling in the United States, they just defer those excess margins to the American consumer. And so, I know a lot of people in a medical audience don't like this, but I was part of the Obama administration, and I really think that CMS has got to negotiate with the pharmaceutical industry. It's prohibited from doing that right now by law, and if it's not done well, it could be disastrous. It could kill innovation. We all know that. But on the other hand, I'll bet that if there was a fair negotiation, Europe would end up paying more, which it really should. The average European lives 5 years longer than the average American now, and they're economically just as well off. So why shouldn't they pay a fair share for their drugs?
No doubt about that. Let me ask you something. So I saw this recently. This was something that was rearing its head a few years ago and I hadn't seen much lately, but I just saw it again. Medical errors are the third leading cause of death in the US, with perhaps more than 250,000 people dying due to medical errors. And of course, I've always wondered, how does one define a medical error? But what is your take on that? Are the doctors killing patients left and right because of incompetence?
I think that's a lot of hyperbole. So, I'm very involved in the National Academy of Medicine, which put out the big study that made that claim, and there are many research efforts. So if you look at it from the perspective of, okay, people, we're all going to die. We usually get pretty sick before we die. And in the course of a complicated illness, there are many things that happen, as every doctor and nurse knows, where you could have made a different decision and it might have turned out better. But on the other hand, most medical interventions have a small effect. It's a cumulative effect of all the decisions and also one word I love is stochastic. The world is stochastic. That is, there's randomness built in. So sometimes it's a combination of things and just some bad luck that happens. And so you can say that medical errors are the third leading cause of death, but most of those are not like normal, healthy people who all of a sudden get struck down by a stupid decision from a doctor. But we also all know that doctors could do a lot better job if they were better supported, which gets back to why I'm at Alphabet. I think, we've got real problems right now, some COVID related, but many before, in the morale of the workforce in medicine. I know you told me, Joel, since you told me this one, I've been quoting you all over the place, the two kinds of jobs, the got to and get to. and I'm with you. I don't have to go to work, but I love what I do. But there are a lot of busy medical practitioners who are overwhelmed and undersupported and going through the day deferring things they know they should do because they're under so much pressure to see patients in a shorter period of time with more bureaucratic paperwork. And that does lead to errors. And so, so to me, the third leading cause of death, that's neither here nor there to me. Can we do a lot better? I think we all should be working on doing a lot better.
Well, I think, the points we made early on that we should be like the pilot in the aviation industry, whereby, if you have a near miss, you tell everybody what happened, and then everybody learns from it. And of course, the aviation industry has done a great job of reducing falls. We've been on this for quite a while. I'm going to ask a couple more questions, and then we'll see if there's anybody in the audience. Have there been, it's interesting, we're always hearing about preventative. I remember when I was in medical school where my professor said, preventative, he said, all you got to do is don't smoke, don't drink, get some exercise, and make sure your blood pressure is good and get your vaccines. He said, that's all that we know of preventative health that works. There's a whole thing now about, individual medicine and personalized medicine and throwing genetics in there. But it seems like an awful lot of, as you were saying, complications when preventative things are, there's actually never been much other than blood pressure treatment that's been shown to prevent death, is there?
Oh, no, I would disagree with that. But I would agree with the general statement that you made. I'm working a lot right now on chronic disease management because I'll just give you an example. I was at the Heart Failure Society meeting, first in-person medical meeting in 18 months for me. So it's really, and I ran intensive care units for 25 years and took care of patients with end-stage heart failure. So it was like going home for me to this meeting. Saw a lot of people face to face, and we all had masks on, of course, but it was good. And so here's the problem. You got 1,300 heart failure specialists. You got 33,000 cardiologists. You got 6 million people in the US with symptomatic heart failure. The numbers don't add up. So, we're working hard on a digital backbone for chronic disease management. There are many startups doing this, not to replace doctors, but just you're going to need nurse practitioners, PAs, community health workers, and you need a digital support system to make it so the quality is good, at least in my opinion. But when you boil it down for all the chronic diseases, it's kind of what you said. They're like 8 basic things, regardless of what you have. You should exercise, you should eat a reasonable diet. Now, don't ask me exactly what a reasonable diet is, but we know the general dietary principles. You should, I would say you should only drink alcohol in moderation. Drink no alcohol, I don't know about that. You should be on the right medicines, which is a doctor function. But if you're on the right medicines, you should take them as prescribed, which is a huge challenge, as you know. And you should not be addicted to drugs, which is a massive and growing problem in our society today. And you should not use tobacco products, period. That's kind of it. And whether you have a chronic rheumatologic disease or coronary disease or COPD, that basic backbone of secondary and primary prevention is the same, yet it's so hard to do, isn't it? And, here's an analogy for you to think about. People say, why can't Silicon Valley fix this problem? Well, the problem is Silicon Valley is built on immediate gratification. It's your next click that matters. If it's Amazon, it's getting that product right away, delivered faster than it could have been done from you trying to figure it out yourself. Most things that are good for you in health are actually not gratifying immediately. It's not doing something.
Yeah, sure.
And the example I use about myself is Bojangles biscuits. I think they perfected the Southern biscuit on a mass scale. I love it. And every time a three-pointer is scored in Cameron Indoor Stadium, we've had season tickets since 1983. the Bojangles sign lights up and they're selling them right outside. And I literally, my mouth starts watering. So that's the, and not doing that takes executive function. We haven't figured out how to make that executive function work, but we are working on it.
Absolutely. Well, listen, let me see if I've got any hot chat questions here, Doctor. And let's see here. Well, there's got something saying it's been outstanding. Let's see if there's a Q&A here. Let's see what this is. Let's see, it says, what would be the best way for physicians with an interest in better communication with the lay public on complex medical issues to become involved with Google Health?
Yeah, I say stay tuned. We've started with organizations because dealing with individuals there are a lot of them, and it's going to be more complicated. But what we hope to do, as I said, is build up a corpus of videos that can be tailored to the needs of different patients with different reading levels and different languages and different health problems. And once we get that sort of done, we want to move on to the individuals. Like, I had no idea, the most popular doctor on YouTube is someone named Dr. Mike. I've never heard of Dr. Mike, but he's got millions of followers and has a pretty interesting show that he regularly puts on. But when we go to the individual docs, what I hope we'll have is something that is sort of white labeled, if you will. That is, there'll be videos that are helpful to people, but they could be inserted into your practice. Because the thing that doesn't make sense to me is every doc and nurse in every institution trying to put together their own materials. It's just, probably for any given condition, there are a set of materials that are going to be the best. But since patients trust their doctors and nurses, if it's something that you agree with, and you might have like an intro. I'm Dr. Silverfield, and here's what I think. And by the way, you really ought to watch this next segment because it's going to give you some information that'll be helpful. So that's where we want to go. And if you're really interested, I'd say in about 6 months, you'll see a pretty big campaign to try to rev this up and get back in touch with us at that point.
Sounds. So here's another question. Someone is wanting to know if Google is going to develop its own EMR.
I'm sorry to tell you that we've thought about it. And the problem with the EMR that we see is that it's a billing instrument primarily. And we don't want to be in the position of being the billing instrument for healthcare. And it's so instantiated into institutions now with major investments that we can't supplant it. But here's what we are doing. And I think others are doing the same thing. If you think about what we know about health outcomes now, they're the traditional transactions that occur in the clinic. The patient comes to clinic, you write prescriptions, there's a note, it's in the EMR. But we also know now that where the person lives is really important, and who they hang out with and what they do in their social activity and what the environment is. If you live near a hog farm in North Carolina, your life expectancy is something like 10 years shorter, for example. And so we need to integrate all that information into a format which can be useful and not add burden to the clinician or the patient. And that's what we're working on. And if you want to see the product in evolution, Google something called Care Studio, and you'll see a demo of it. All I can say is, over the last 15 years, as search has become such a complex and integrated search engine, there are a lot of tricks of the trade that are proprietary that when applied to the EMR can do things that's very hard for anyone else to do. You know how when you're typing now in Gmail or whatever, it fills in the sentence for you. Also, when I talk now at a video conference with people around the world, the text is coming up in real time, regardless of what language they speak primarily. And one of the fascinating things is if you get to 2 minutes later and the artificial intelligence realizes that the context that you were talking in it's different than it thought back 2 minutes ago. It goes back and corrects it. And so that means that things like, with EMRs now, if you misspell things and you got to do all these clicks, we foresee an environment much more like what it's like when you're in a Google search environment, that things are at your fingertips and you're not doing multiple clicks. But that's not replacing the EMR. It's really supplementing it and giving it an interface, which will be more useful.
Very good. Very good. Well, I can't tell you how much I appreciate it. One last question. You spent most of your early life in South Carolina and most of your later life in North Carolina. Do you prefer the mustard-based or the ketchup-based barbecue sauce?
I know this sounds like a evasion, but it's actually a toss-up for me. And if you offered me either one, I would eat it in a half a second. But I did have a funny experience in my confirmation hearing. I was championed by Richard Burr, the senator from North Carolina, who I got to know pretty well. And he was talking about, how great I was from North Carolina. And Senator Scott from South Carolina chimed up and said, wait a minute, he's a South Carolinian, not a North Carolinian. I got into an argument in the Senate about where I was from, which was good for me because it ate up some of the time where I would have been grilled by Bernie Sanders and Elizabeth Warren. So I was pretty happy that the time was eaten up.
No, that's funny. I think you said Rand Paul had taken a couple of shots at you as well, which your fellow doctor. So first of all, I would like to thank you again for your time. It's just fascinating picking your mind. And I want to announce on behalf of Tampa General Hospital, a donation was made to your charity of choice, which is the Durham chapter of the American Heart Association. So thank you again so very much. This concludes our virtual event this evening. In case you missed any part of tonight's event, it has been taped and will be sent to the membership in the next couple of days. Stay safe. Have a good rest of the evening. And Rob, what a pleasure. Thanks so much.
Thanks, Joel. Take care.
My best to Lydia. Thank you.